I welcome you who are here in the hall, and I welcome those who are Zooming online and joining us from afar. My name is John Bowis. I'm a former policymaker, politician in two parliaments, in the British Parliament and in the European Parliament, 10 years in each. And I was a health minister, and then as a European politician, I was a spokesman on health for the largest group in the Parliament. In both parliaments, I certainly tried to put diabetes higher up on the agenda and to try and encourage the production of national plans for diabetes over the years. Well, I'm here as a policymaker. I'm also here as a patient. I live with type 2 diabetes. I've done so for the past 13 years, as far as I know. And I don't know when I started to have diabetes, but it was probably quite a lot before that. I suspect it was undetected for some years. And my own diabetes was found quite by chance. I was having problems resolving a health issue, which was a lymphedema problem that I had in my legs. And I was talking to a friend of mine who has a garage business. And he said to me, "Do you think you've got a blood sugar problem?" And I said, "I don't know, I'll ask." I did, I had. So if you have a problem with your blood sugar, check it out with your local garage. They may be able to point you in the right direction. Over the years, I've learned about the links between diseases, and the diabetes and depression dialogue of Norman Sartorius and others, and recent reports. And of course, we've come out recently, we're still in the COVID years, and we have had a lot of horrendous problems with COVID. We've also had some quite positive outcomes, and one of them is the greater understanding of the links between diseases. And where diabetes is concerned, we know, of course, that if you live with diabetes, you can have a much worse experience of COVID. What we didn't know, I think, is that if you have COVID, there's quite a chance that you will have diabetes triggered in you. And that's something we learn and take note of and try to do something about. Well, as an MP in the European Parliament and health spokesman there, I worked with the IDF and FEND and others to establish the European Parliament's Diabetes Working Group. Its aim was to, and still is, to raise the profile of diabetes among European Union policymakers and to press for an EU policy response to the growing prevalence of diabetes. We succeeded in persuading a majority of the members of the European Parliament to sign the written declaration calling for action, and that we succeeded in getting, which meant it became a European Parliament policy and had to be responded to by the Commission. And we fought for screening, education, disease prevention, health promotion, disease management, and a partnership between individuals and diabetes health and care professionals, and the empowering of people to manage their own condition when they were able to, but to manage it with a certain knowledge that they were being monitored continuously, so that if they were not managing properly, effectively, someone would step in and say, "We need to check this out." And of course, we needed more research and the resources for all of these things. Well, in 1989, wasn't it? You'll know as well as I do that we had the European nations agreeing unanimously in St. Vincent in Italy to recognize and tackle the problems of diabetes. 10 years on, in 1999, the year I entered the European Parliament, the Istanbul commitment showed that there had been more words than action by government health departments. And the nations of Europe again agreed, again unanimously, to set and meet goals and targets and high standards of care. And now we're in 2022. We have progressed considerably, not least through digital E and M health, but we have a long journey yet to cover before we can say we have an adequate system around our various countries. And we have a long way to travel as politicians, as nurses and doctors, as scientists, as carers, and as individuals living with diabetes. Well, today we are met together to look at some of the ways we can help governments to meet the challenges of this ever-growing and global threat to human health and economic wealth, and to meet the needs of those living with the disease. And we have three speakers to present to you, and I'll ask them each to come up in turn. And the first one is Professor Katherine Barnard Kelly, the Chief Science Officer at Spotlight Consultations and based at the University of Southampton in the UK, a chartered health psychologist specializing in the psychosocial impact of disease, and as principal investigator led the team to achieve the first ever diabetes psychosocial FDA-approved MDDT qualification for the INSPIRE measures. Katherine.
Fabulous, thank you. Thank you so much. I'm absolutely thrilled to be here today to talk about this hugely, hugely important issue. I am a psychologist, so I am the eternal optimist, and I do believe that we have many, many challenges, but as the other speakers are going to cover after me, I am confident that the future actually is going to be much better and that we are going to address these inequalities, some of which we managed to create for ourselves. So here are my disclosures. So here's the thing. As many of us know, 50 years ago, John Tudor Hart wrote the inverse care law in the Lancet Diabetes, and says clearly that the availability of good medical care tends to vary inversely with the need for it. And the challenge is that has not changed. 50 years later, it has not changed. And we know more now about the impact on different diverse groups. But what we are struggling to do still is to address that impact in a fair and equal way. Those who need healthcare the most are least likely to be able to access it. And inversely, those who are most capable are most effective. So it's not just about access, it's also about engagement. And we need to rebalance how people are able to be effective in their engagements with the healthcare that they access. So the elephant in the room, and this became really, really clear during the COVID pandemic and the lockdowns, is that relatively privileged people are able to use their access to digital technologies in order to benefit remotely from health and education. And the challenges with education is that those who exist in digital poverty, for example, who don't have access to the internet at home, who don't have multiple devices in order for everybody to be able to access education in the same way, they're the ones that struggle the most. And that gap now broadens between the disadvantaged and the advantaged, because we now have had long, long periods of time where people are simply not able to access healthcare and to access education in the way that others clearly benefit from. And it's worth reminding ourselves that, in the UK, around 10% of households do not have access to the internet at home. But globally, 40% of people do not access the internet at home. So you can see this exacerbation of difference between the different groups in society. But when we look at healthcare and the way that it is structured and delivered, there are a number of inequalities literally right at the top that are reinforced at every level on the way down. And then when you get to the constraints of delivering healthcare as a healthcare professional, we all have inherent bias. They're defense mechanisms. But when that inherent bias gets in the way of delivery of equal and fair access to healthcare, and instead of becoming facilitators, we become gatekeepers to technologies, for example, then that simply reinforces the inequality within the healthcare system. So when you look at gender and ethnicity imbalances in the senior levels of healthcare in the UK, for example, you can see that women and people from ethnic minority groups still hold very, very few positions of power in healthcare systems. And if people are not represented equally at all levels in the healthcare system, how can we possibly understand and meet their needs? We are excluding them. But it's not just in the way that healthcare systems are structured, it's also in the way that we deliver clinical trials. So that you can see here, African American and Hispanic and Asian minority groups, their participation in clinical trials in the States, for example, is disproportionately low. And similarly in the UK, we really struggle to recruit. So when NICE are reviewing and evaluating the evidence in order to develop guidelines, the data is already skewed. So people are at a disadvantage literally right from the very top. But just to say that there are inequalities, and it's like, well, say 7% of Americans don't have access to the internet. That really skips over the fact that that is 23 million people. 23 million people. And when we look at age and race and income and education levels, you can see there are some really clear differences within these stratifications around access and engagement. So it's not useful or helpful in any way to clump together disadvantaged groups because there are so many differences within those stratifications. And when we look at the diatribe data, Kelly Close and her team in the States, again, you can see the disadvantages. So those with the highest income, for example, have the lowest HbA1c in people with diabetes. You have least empathic care for those most disadvantaged. This has nothing to do with money. Empathy doesn't cost anything. It's the way that healthcare is delivered to different groups across the population. And the challenges, as I mentioned earlier, around access and barriers and challenges that we kind of create for ourselves. So, take an Illinois example. What happens is, in Illinois, is that primary care physicians can prescribe continuous glucose monitoring. However, the coverage policy dictates that in order for the state to pay, you have to have an endocrinologist consultation. The challenge is that Illinois is a huge state with not enough endocrinologists, and of the endocrinologists that work there, they don't all work in diabetes. So you can't get to see an endocrinologist, and therefore you can't have CGM. We've created that problem. That's a structural problem that inadvertently we have created in the system. And another challenge, alongside digital access, which is a natural barrier, transportation is also another barrier to access and effective engagement with healthcare. Because if you can't afford or you're unable to travel to your appointments, you can't access healthcare. And during COVID, lots of the states in the US, for example, they rapidly shifted to remote teleconsultations, which was great, and reimbursement was situated within that. But as soon as the lockdowns ended, many states withdrew reimbursement and returned to in-person consultations, which then stopped people from being able to go. Now, Gary Puckrin has done some really interesting research, and he looked at a Medicare population. So this is a universal benefit for adults aged 65 and above. So there are approximately 38 to 39 million people on Medicare in the US. Of those, 10.5 million have a diagnosis of type 1 diabetes. This is 2019 data. And when you look at prescribing of blood glucose monitoring across race and ethnicity, you can see that the white population prevalence of diabetes is in 24%, by far the lowest of any ethnic group. And yet, ethnic and racial minorities receive a lower quality of care and they have worse outcomes. So this is not a numbers game in terms of delivery of care, because the white population is 24% of diabetes. Far outnumbers. And then when you look at the associations between race and ethnicity and engagement to prescribe glucose monitoring, again, you can see some really stark differences. So you have 4 groups of real-time CGM, any method of blood glucose monitoring that has a prescribed pattern, any method of blood glucose monitoring without a prescribed pattern or not using at all. And you can see of 1.3 million people, literally nearly 75% either are defined as BGM non-adherent or are not receiving blood glucose monitoring at all. And they're all taking insulin. And you can see further down, you look at the percentage of white adults, older adults, they are much more likely by a number of 3 to 1 to be using real-time CGM as compared to other groups. Yet they're the smallest group. So, what Gary Puckrin and his team concluded was that race is clearly associated with increased hospitalizations and costs of diabetes care. The absence of any form of blood glucose monitoring was associated with higher rates of comorbidities. And people of colour are less likely to use real-time CGM despite the universal benefit of Medicare coverage. And when you think of another universal coverage of healthcare, like the NHS, for example, where I live, you can see treatment targets, type 1, type 2, England and Wales. Less than 20% of adults with type 1 diabetes are achieving treatment targets consistently year on year. And we have amazing technologies, we have brilliant insulins, we have like the most advanced technologies and therapies, and yet we are not achieving treatment targets. But maybe that's something to do with the fact that we're not giving people the care they should be receiving. And you can see here that less than half of people are receiving all of the care processes that they are supposed to. But again, this is more complex than simple numbers. Care processes mapped by clinical commissioning group and local health boards. You can see clear patterns emerging around the most and least deprived areas. Similarly, in treatment targets, you can literally map it. And it also, unsurprisingly, maps to indices of health and multiple deprivation. And worryingly, local government data shows that public health cuts are disproportionately applied to the 10% most deprived areas as compared to the 10% least deprived areas, by literally double. So in the most deprived areas, public health spending has reduced by an average of 31%. And yet, in the least deprived areas, it's only 15%. So where people most need, they least receive. And when we look at young people and type 2 diabetes, we can see we have just over 1,500 people under the age of 19 in the UK with type 2 diabetes. And already you see patterns emerging that show those most vulnerable are in these different groups, and they're least likely to receive the care that they need. And when we look at tech access, again, we can see significantly lower use of pumps or CGM, for example, amongst Black and ethnic minority children. And we know that the difference year on year over the last 6 years in terms of access to technologies has widened and not got better. And there is a lot of work ongoing to try and reverse this trend and to stop these inequalities perpetuating. Yeah, 1 minute, yeah. And again, CGM use by ethnicity and deprivation. See the V. It's really stark. But last year, things did start to improve. And I'm sure that positive trend will continue. But it's so important to look beyond the numbers. Look beyond this, oh, it's a small percentage, oh, it's not very many people. There are distinct differences that need to be explored. And this is not a problem for one person to fix. This is not a government problem. This is a problem for everybody to fix. And we can only fix it if we work collaboratively across all key stakeholder groups. Thank you.
Katherine, thank you very much indeed. That was an excellent presentation, and I suppose highlighting particularly the deprivation that there is, not only between countries, but within countries, between and within different racial groups within countries too. And as you rightly say, we all need to tackle this. So I'm now going to come on to our second speaker, if I may, and that is Sonia Sidhu, who is a Canadian politician. She's elected a Member of Parliament in the House of Commons of Canada to represent the Federal Electoral District of Brampton South in 2015. And as you will hear, she has a lot to do with diabetes on her agenda. Sonia.
Thank you. Hello, everyone. I'm Sonia Sidhu, Member of Parliament, Federal Member of Parliament from Brampton, which is in Canada. And I'm also chair of the All-Party Diabetes Caucus in our Parliament. And I'm so glad to be here in Lisbon for the IDF World Diabetes Congress 2022, where same-minded people, we can advance the agenda, how we can combat this disease. And I also want to thank PG Parliamentary for Diabetes Global Network for their work, because the policymakers can also involve in that, and they can listen and shape the policies towards that disease. As we know, diabetes is a very serious chronic disease that impacts millions of people. In Canada, from the data from Diabetes Canada, 11.7 million people are affected with diabetes or pre-diabetes, which is a big number. We all know diabetes is also a very complex disease, but there's still significant work ahead to ensure better health outcomes for those affected around the world, which is why we're here today. I just want to share a little bit about the work done in Canada and the journey to creating a national framework for diabetes, which is my private member bill. As a member of Parliament, I sit on the House of Commons Standing Committee on Health, which studies issues that relate to health of Canadians, oversees the Health Canada Department, and has oversight of 4 health-related agencies before entering policies. Before that, I worked in the healthcare field for 18 years, where I saw firsthand a significant impact that diabetes has on our healthcare system. In my city, because I'm from Brampton, the rate of diabetes more than doubled between 1996 and now. 1 in every 6 residents is living with the diabetes or pre-diabetes. And some Canadians are at increased risk of diabetes, such as we heard from the speakers, South Asians, Black Canadians, and Indigenous populations. We also know that that diabetes disproportionately affects on many folks. So a healthy diet, staying active, and exercise can all contribute to the prevention of this disease on top of research, treatment, and collaboration. I know that we needed also focus on prevention and spreading awareness. Awareness is the key for this disease. Since 2015, I have used my voice as a member of parliament from Brampton in Canada, Canadian Parliament, and as the chair of All Party Diabetes Caucus. In 2019, I tabled motion M173 in the Canadian Parliament to recognize November as the Diabetes Awareness Month in Canada. And also team up and continue to do this with the local organization to provide a diabetes mobile screening unit. What we did, we brought a mobile screening unit where all parliamentary can screen their and they can assess their risk factors, and then they can shape the policies, and then it familiarizes them with this disease. But simply raising awareness was not enough. I was hearing from patient experts and researchers that we needed a coordinated strategy to respond to diabetes nationwide. So throughout the summer 2017, 2018, 2019, before COVID, I went to consultation across Canada to receive input about healthy eating strategies and diabetes prevention and management with feedback and recommendation being delivered to the Minister of Health. Also met many professionals and experts. So the same conferences, why this is so important, but you can learn a lot from them. That is what I heard back in Rome. We had a conference in Calcutta. So when we are attending, when you're learning, and then you can shape those in the policies. So moving forward, this is something I did together, and then with a national framework for diabetes, which I want to show. This is that work I gathered from those conferences. Sorry. The parliamentary from the All Parties Caucus, when I collected this information and then I introduced my private member bill in February 2020, an act to establish national framework for diabetes in Canada. And I was proud to say that in June 2021, my bill passed with the unanimously from all parties in the House of Commons and also in the Senate. The Diabetes Caucus, we have a Diabetes Caucus where all parties, parliamentarians are, we work together, and this is a great place to bring world-leading experts to learn about ongoing work. Caucus members share their experiences with each other, they are learning from them. And they are dedicated to encouraging the research and innovation to advocating for improvement for diagnostics and care, which is delivered the most Canadians through their prospective provinces and territories. And also I held a Defeat Diabetes One Step Step Challenge on Parliament Hill. This is also something, it's encouraging parliamentary to get active, and more than 100 parliamentarians of them accepted this challenge, wearing step counters for 10 days to log their efforts to take the most steps. It was a great way to, to encourage decision makers with the diabetes warning signs and encourage them to make a healthy lifestyle choices to prevent the onset of type 2 diabetes. So if I came to the national framework for diabetes, that bill, when this bill passed, the next this term, the next federal budget, there was a $35 million investment set aside over 5 years to develop this framework. In October, I believe on 5th October this year, alongside our Federal Minister of Health, Jean-Yves Duclos, I was pleased to table the National Framework for Diabetes in Canada. The framework means that Canada will now have a coordinated response to diabetes that will improve health outcomes for everyone. It is focused around prevention, management, treatment and care, research, surveillance and data collection, learning and knowledge sharing, as well as access to diabetes devices, medicines, and support. We heard from Katherine, data surveillance is very, very important. So that is why this bill is asking for that too, because we heard from so many experts. Without data, we cannot advance our policies or we cannot make our programs. An important component of this bill is now the framework is research, how we support our researchers. Canada has a proud history as a leader in diabetes research. Last year, we celebrated the 100th year anniversary of the discovery of insulin by the University of Toronto graduate Sir Frederick Banting in 1921 in Canada with the assistance of Dr. Charles Best. Canadian discovered the extract of hormones that would go on to save lives and provide treatment for the millions of people living with diabetes around the world. The framework for diabetes offered the path of build on the legacy when insulin has saved the lives of millions of people of Canada across the world, but it is not a cure. We need to focus on prevention and awareness. There were 6 pillars which I heard from the experts like you, and data surveillance. Why this is so important that we can make the program and then we can do prevention and management of the diabetes. This is why the Government of Canada continues to make investment in research, prevention, and early detection of diabetes, so the fewer people develop this condition and better treatment are available when diabetes occurs. Through the Canadian Institutes for Health Research, known as the CIHR, our government is supporting health researchers towards more effective treatments and ultimately a cure for diabetes, including type 1 and type 2. Since 2015, CIHR has invested over $238 million in diabetes research. Why I'm telling this? Because without funding, research cannot move forward. It's important to fund the researchers so they can hard work on the research and we can find a cure. And also want to, if you visit to Canada, there's a banding house in London, and the flame is still burning, and it only can extinguish when we can find a cure. So this is something, monument, we all can think about it. It encourage all the researchers to find the cure, but without funding, they cannot move forward. So that is why all the parliamentarians, they have to encourage the government to make the policies so where they can fund the researchers. So Canada is a federation, and the healthcare delivery is the responsibility of our provinces. This is why Canada's National Framework for Diabetes is a plan that engages provinces and territories to improve health outcomes for all Canadians. It is important for me to talk about the next steps. So within 5 years, the minister must prepare a report on the effectiveness of the framework, the present state of diabetes prevention and treatment, and revisit the outcomes if there's any changes we need to make, and then that time we can assess that and make the needed changes. Identify priorities and the way forward to address diabetes. In First Nations, we have most prevalence in Indigenous communities, First Nation, Inuit and Métis populations. So my message is this: I know I'm so thrilled when I'm hearing a lot of experts when they're talking about, we are listening through seminars, and this is the way we all can spread in the world, and then we can prevent so many people's, we all know the serious consequences comes out from the diabetes, untreated diabetes. So let's combat this disease and its life-threatening complications by making our diabetic population familiar and diabetes warning signs, encouraging healthy lifestyle choices, and by making access to the best quality of care possible. And I look forward to learning from more engaging, more sessions, and let's work together to combat this disease. And thank you so much, the work you are doing, all the researchers, all the experts, and thank you all for joining this conference. And this is the way to explore to the world, and then with prevention and management of this disease. Thank you so much.
Thank you, Sonia, very much. That's congratulations, I should say, for all the work you've put into this, and the report you've produced and had adopted by the Canadian Parliament is impressive. And you refer particularly perhaps to the need for data, and it's all the data. I often think that we think of data in terms of the cost of a disease and treatments and what have you. We forget about the cost to countries of people being unable to be active in an economic sense, so they can't earn and they can't pay taxes. That applies to people with diabetes, applies to their carers. And if governments understood that better, they might see the point of investing in better services. So let me now turn to our third speakers, Professor Partha Kar. And I note that he created TAD, talking about diabetes, so he's going to do just that. So he's the National Specialty Advisor for Diabetes with NHS England and co-author of the National Diabetes GIRFT report.
Thank you very much. Thanks very much for the invite. So I'll do some basic stuff while my slides are coming up. I think I've said this already in this meeting a few times. You will hear a lot of academics and clinicians say that they don't do politics. You hear a lot of that. And I'll tell you, having done a national role for 7 years, you cannot change health outcomes if you don't do politics. Now, it might be a politics with a big P, it might be with a small p, you can choose your P, but it is absolute nonsense to say you cannot do it. And I had this conversation with a lot of academics, a lot of clinicians. I said, what do you want? Do you want your research to be a PDF, your CV, or do you want it to be in some people's lives? Because if you do, then whether you like it, like them, or like not, and I will say this because I have interacted with politicians of every single colour possible in the UK, and Adrian will know my history, but I interact with, we've seen many, many health secretaries, we've spoken to the opposition, and I do not fundamentally believe that, and I'm not saying this because we've got politicians, I've already said this in a few sessions, I think we need to step away from the narrative that politicians are just evil people trying to stop anything happening. In the main, people go into it because they want to do the right thing. You need to have your ammunition, you need to have your data, you need to show them the way, you need to show them what the benefits are, you need to show them what stakeholders actually mean if you want to make changes. Just passion, it's not going to work, because politicians face passion from 25 other areas, and they have to balance that out. And I think one of the first things, and Sonia, I love the bit you mentioned on data. Without data, you're blind. Without data, if you put in policy, all you will do is widen gaps. Because I tell you what we do. We love a lot of doing this in healthcare. You'll see us doing, do you know what, you can get this insulin or this technology or this device if you fit these criteria, right? Let me put it across to you. If you've got time to put food on your table and you don't have a worry about the roof on your head, you will find a way to fit yourself into the criteria. That's how it works. I'll give you one example. What do we say in the UK or in other countries? To get an insulin pump, you have to come to us and be educated about it. You go like, okay, well, that sounds reasonable. But you have to do it on the dates I choose and for 5 days of your life. Now, extrapolate that to somebody who's holding down 2 jobs on a 0-hour contract. They're going like, that's just not going to happen. That's just not going to happen. Well, then you can't get the pump. Then you go, well, then I live without the pump. That's how it is. So I think that's the narrative which we probably need to get past. So I'll show you a few things, and I'll do a quick presentation because I'm quite keen on having that conversation. So the NHS, those of you who are politicians in the UK, the NHS loves doing plans. We love making plans. We don't deliver on them. We love doing our plans. This is what we do. Every few years, we make plans. So when we did the latest version of the plan, the long-term plan, and I think this is the point I always make plans which are please realistic. Don't make plans you cannot deliver. And people keep on doing this. You have people come to us and go like, somebody said to me, we want to eliminate all heart attacks in the world. And I went like, okay, that is impossible. And they said, no, but we need to aim high. And I said, okay, I go for runs. That doesn't mean I want to be Usain Bolt. You need to aim high, absolutely, but you also need to be realistic about what you're trying to do, trajectories, targets, etc. So we made a plan. We said 20% of our type 1 diabetes population should get this Freestyle Libre. We'll get continuous glucose monitor for everybody with pregnancy. And we said all type 1 diabetes to have access to these online platforms. Okay, these are achievable goals. So where do we get to? And I think the reason we did it is this. National data, as Kat showed, shows poor uptake of technology. If you're rich, you get it. If you don't get it. It's quite straightforward, right? Your ethnicity matters. And then about people's understanding of what regulatory bodies actually mean. There are different ways of doing it. Most people don't understand the law. Most people don't understand anything. Most clinicians are very good at clinics, but that's all we are good at, which is the problem. And thereby, when you get stuck, nobody quite understands where to go with it. So what you get is this. So how powerful is all the regulation? So we got a technology appraisal. Those of you know, do you know what a technology appraisal? Technology appraisal from NICE, which is one of the most cost-effective body in the world, says it's a legal mandate. You can't buck it. You can take the NHS to court if they're not delivering a TA, right? And you go like, well, that's sorted. No. 20% of people got it. At the moment, there's 69,000 people with type 1 diabetes who would fit a criteria for getting a pump but not on it. Do you know when the criteria came out? I went to a center and they said, the guidelines need to update. And I said, what about the last guideline? And you haven't even fitted anybody onto that. It came out 15 years ago. 15, not 5, not 3, not 2, 1, 5, okay? So we always talk about it and go like, well, it's not just the guidelines that's going to make things happen. So we managed to get there, and because we started at 20%, we got to 50%, which was fantastic. We have had 98% of pregnant women across the country on CGM. The reason I say this, because we didn't put any criteria, apart from saying if you're pregnant and you got type 1 diabetes, you get it. None of you need to really jump through 3 hoops, you need to, turn around 3 times, and all that sort of stuff. Guess what? When you got 98%, you have eliminated all gaps because you got everybody, right? And we have just got data which we're about to publish. Do you know the impact of that? After 13 months of doing that, we have had now statistical drop in admissions to our neonatal care units. That's changing lives by taking away criteria, right? None of the discussion about, black woman, white woman, who's getting it. I mean, no data. For example, the UK maternal mortality. If you're a black woman, your chance of dying is 3 times more than a white woman. Okay, so these are sort of nice things. I'm not going to bore you with that. So we are now, this is the latest data we have got till September. We got 83% of people with type 1 diabetes now on a non-invasive sensor. How do you do that? Because we changed the guidelines. There were guidelines which were like you had to prick your fingers 8 times a day, you had to be a worker of certain description, etc., etc., etc. When we went on school, not really, you need to have only one criteria. Type 1 diabetes, finish it. Guess what? You were at 83%. That's what you need to do, evidence-based, to do that sort of stuff. So we got all these closed loops. Now, this has been a fantastic journey for us. That's lovely. Great. 5 years of my life. We have been punching things through. Looks amazing. And you're thinking like, well, he's just coming around saying all good stuff. So that's good. So where have we got to? 80%, 98%, and our pediatric population side, they're all going the right direction, as Kat mentioned, and DKA rates are dropping. Now, diabetic ketoacidosis rates across the UK is not dropping because clinicians have done anything phenomenal. Do you know why it's dropping? Because we gave them tools to look after their diabetes better. It's dropped in the middle of a pandemic where you couldn't see clinicians for love or money. All we did is that here's a tool so you can look after yourself better, and it's got alarms and will tell you when it's high and low, and this is what you need to do. It was not rocket science. I can assure you it wasn't rocket science. But we have problems. Look at that. And here is a fundamental problem. There's another role nowadays I do in the NHS beyond diabetes. It's been a year now. which is tackling racism, sexism, etc. in medical workforce. And I think we need to step away from this whole notion that clinicians, when they put on their coat and they go to work, suddenly forget all their biases in life. They don't. We're the same human beings. We carry our biases into work. If you're biased against women, if you're a sexist person, you do not treat women the same. Menopause research has shown that time and time again. All men did research in the world were not really important for us, so you've got no research on menopause. There's nothing. There actually nothing exists. Funny that, because that's how it works. So we've got a problem in deprivation and this. So, but just so the importance of data is that what do you do with data? And this is a problem that we have in data around health system. There are 4 purposes of data in my book. You show there is a problem. You consolidate that the problem still continues. You have strategies to now do the problem, and you use data only to track progress. End of story. But what we do with health is in probably stage 2 and 3, which is everybody's going like, yes, it was a problem 2 years ago, but is it still a problem? And you go like, okay. And you know this not just in diabetes, but you see that in every single, any person who's faced racism, sexism, and we will have gone through this discussion 25 times over. Yes, it was really tough in the 70s, I know, but is it really a problem anymore? And you go like, it is. And honestly, it is. And they go, no, let's do some more data. And it's really frustrating for health systems when the people keep on doing that. And we never have got to the stage where you go like, I just want to hold data and accountability about what you're doing. So that's what we're going to do right in this. We've just started this work. We're drilling the data into every system, right? And the reason for drilling is also to have that very straightforward conversation. When I show the data which says a black child has got less chance than a white child, what do you think the response comes back from clinicians? Do you know? First thing that comes back, the data's wrong. Can't be me, because I'm so good. It's impossible. What do you mean? And you go, no, the data's absolutely fine. And they go like, are you calling me a racist? I go like, well, not really. I've just shown you data as it is. There might be bigger problems than that. But having said that, I've just shown you the data. And I'll bring some investment into it as well. But with the investment, and now that you're aware of the data, if you haven't changed it, I'd like to know what term you would like me to call you by. Because I'm happy to use that term, whatever the term is. So that's what we're doing. So people said, we need some money. And I said, well, I don't think you really need money to give a black child the same as a white child, but okay. Because that's what we do in policy. We'll bring some money. So what we have done, we've drilled data. These are the centers we have picked because they have got the worst gaps in place. And we've said to them, we're going to give you money, but we're not going to say what you need to do. I want to see initiatives which are different. I don't want to have plans, and we have rejected plans which said, oh, I just need another 2 nurses. No, that's not how you close gaps. Give me ideas, councils. Give me ideas about language. Give me ideas about how you're reaching out to the really deprived people. How are you reaching out to people who are on food banks? What are you doing with them to get them there? So that's what we have. So we've got a national program which has just been launched last week, which is across the NHS, and diabetes, as you can see, is one of them. And we want to actually see whether you can close the gap. And I must say one thing here. People need to stop being worried about failure. If you're trying something which nobody has cracked so far in the world, you have to have initiatives which people can turn back. And it's important for these sort of meetings because you go like, don't try that, we tried, it just did not work. Don't do it. Right? It's important to do that. So what we want to do with these centers is, here is the money, here is what we have put in, here are the initiatives, here is where the data closed, here is where the data didn't close. Because we all need to know what works. Otherwise, you go around in circles, doing the same thing in different countries on loop. And those of you who've been in the system long enough will know exactly what happens. How many times you'll have seen a plan and you're going like, oh my God, I've seen this, haven't I? I'm sure I've seen this plan 3 times over in my career. And those of you in the NHS or any health system will know. Organizational memory just does not exist in health systems. So final top tips which I go, you need drivers from the policy side, and you need a big role of industry on this one. So we regularly interact with industry. So for example, when we negotiated a deal with Dexcom to bring their product into the UK, we said to them, we'll allow you in if you give us some way in for people who don't have an internet or a smartphone. What do I do with them? So they're obliged to provide the NHS with X number of devices, and that's when they get entry into the system. So that distributes out to hospitals, and you ask the patient, do you have a smartphone, do you have internet? And there are, funnily enough, believe it or not, some people who go like, well, I don't have a smartphone, can't afford one. in which case we give them another device. So that's pretty much it, data to convey, data to track progress. I'll leave it there. So, but in short, it's doable, but it's not supposed to be easy. So I'll leave it there and take any questions. Thanks very much.
Thanks, Partha. That was excellent, challenging. And one particular challenge I recognized from another area of health that I had to deal with, which was mental health. And one of the first reports I commissioned when I was a Minister of Health was into the apparent difference between the levels of diagnosis of severe mental health in people with a black background and those who were white, and the more likelihood of their being sectioned and locked away than whites. And what we found too is that if you compared black people from Jamaica in Britain, they were far way ahead of black people in Jamaica. And so we knew there was some form of what we called then institutionalized racism. And I think we've been struggling to cope with that ever since. But thanks for your challenge there. So we have a moment or two for some questions. If anyone would like to put a question to our panel. Can I see if anybody has a question? Adrian.
Hi. The question's really around data. There's loads and loads of data out there, which is wonderful. But there's even more data being collected on the hour by the people that have the technology out there. What requirements are there, or should there be, for that data to be shared back into the system so that it can then help even more people?
So one of the biggest challenges with technology you have is interoperability. People talk about it because data are locked away. And so I can tell you what we are doing. We are setting some standards for companies as to what data they should share with the NHS. There's a big debate who the data belongs to. I think the data belongs to the person who has diabetes, right? Not to the company. But either way, so that's coming through, and we want to commission products which do that data sharing, because you're absolutely right. That data is a gold mine. I can understand the worries, and I don't need to sound flippant, but I think I've said this already. People are so worried about security with everything that sometimes we lose context, because 11 years ago, I had this revolutionary idea, which was using Skype to talk to patients. And some of the conversations I recorded, I'm not going to put it on paper, but they're absolutely fantastically hilarious. I mean, they were like, what happens if somebody hacks into your conversation? So I have no idea. Why will somebody, a super spy, want to hack into a conversation I'm having about diabetes? That makes no sense. But you can see they're doing it from the right space, about trying to protect me. So I think that's become so worried. And so I think to your question, data has to be shared. And I think that's at least going to be our principle with all the companies. And we know the impact of that. So we shall see how it plays out.
Anything, Catherine? No.
Yeah, no, to your point actually about Skype, and it's funny, isn't it, how you get a pandemic and then overnight everyone goes to Skype. Suddenly it's not a problem anymore. But I wonder this kind of nannyism around, we must protect everybody from everything. Or maybe what we could do is we could give people informed choice and let them decide what's the best way for them to access healthcare.
Catherine, you're talking like a liberal.
I know, imagine it. But yeah, I just wonder, it's like that the whole 5-day structured education thing is one of my bugbears, because there are some really, really cool structured education platforms online. You know, let's just kind of trust people to be a grown-up and go and access it in a way that helps them. Maybe.
It's very, very interesting, because one of the things I've come across so many times is the dichotomy between the politician who wants to protect you from risk and the patient who says, if I have no risk, I have no progress.
Yeah.
So don't overprotect me, but help me to understand and make an informed choice. Sonia.
Just want to add, as a politician, I think, if I'm thinking as a patient, yes, they need a security. Yes, I can understand that, because how, the world is we all seen that. But as a politician, if we can make, that is why this is number 6 on my bill. So data sharing and surveillance, so we can provide the security. This is a safety net, and you know, when people are saying that it's safe, yes, they will share the data. I think without data sharing, we cannot advance our programs, our policies. It's a very, very important step. And then when we provide the safety and security to the population, definitely they will share the data. So it's up to now the policymakers how they can make a. We are in the talks to how to make a national data strategy. So we're all, because in Canada there is province who is hesitant to share the data to the Fed. So when there's a national data plan strategy, that will, I think, it's something, because every country is different. There's a unique circumstances, but definitely people want their safety net. When the government needs the safety net, they provide the safety net. Definitely, we can advance our agenda. Thank you.
Okay. Yes, please. If you can come to the microphone, just say who you are.
Gazelle Fazli from Canada. I just wanted to say thank you to the panelists. Everything you're saying is so inspiring. I'm a researcher in diabetes. I'm also biased because I'm very excited about Sonia's work and what we're hoping to accomplish. No pressure. My question is really around how to transition from this impending cycle of pilot interventions. In Canada, we've had a few, and we know in diabetes prevention what we need to do, and we're working in Peel to try to understand how we can do some implementation science and do diabetes prevention. But I feel that we constantly run into this dead end when it comes to pilot interventions that don't get rolled up into actual interventions and programs that can be more long-term and sustainable, and evaluating it as a challenge on its own. So any advice that you have on how we could pitch that to our policymakers and work around it? Thank you.
Okay, thank you. Sonia, you can
Yes.
accept the plaudits, but also answer the question.
Yes, definitely. It's a wonderful question. That is why this national framework will give this, the tool. Because we have a system where the province is, it's under provincial jurisdictions, healthcare delivery. So when we are giving this national framework, we already enrolled on the 5th of October. So now the consultation is going on. And then when every province is signing that will be there. And the other thing is that through promoting the prevention, there's Excellency Award is open now. You can apply that, and that this is something it's the federal government is doing. But again, when the provinces is signing their agreement with the Fed, and that will be enrolling in that. So Alberta is already doing the great work, and then I'm hoping that Ontario will do that, which is Peel. Thank you for the question, and then I'm very excited on that.
Okay, thanks. Partha.
Yeah, about 6 years ago, we decided not to do pilots anymore as a national team, because we tried so many pilots. We just went for a national program. So a national diabetes program, we just covered the whole country. Because there needs to be a point when you stop doing pilots, and basically it's a concept. We did national rollout. We have all our programs are national rollouts now. Because if it works in the UK, it's going to work in Canada. It's going to work in Malawi. That's how it works. And what is your pilot going to show that you don't know, is my question. It's a bit like saying, I'm going to intervene with something which improves X, and you go like, well, if it's happening in other countries who have got diabetes, it's going to happen here too. And then what do you do if it doesn't work? You're going to stop doing prevention? You're not going to do that either. So now you're stuck, because you're not going to do another pilot. So as a policy, we made a very clear, 6 years ago, we said we're not going to do any more pilots. We're just going to roll with everything. We have particular bits we focus on, and we just do national.
Okay, so Catherine, can I put the question to you, but with the additional question of if you don't have pilots, you don't have prioritization, how do you allow for different variations, shall we say, in timing, if not in the full policy, in different parts of the country?
You do a really good process evaluation. You literally, process evaluation is underrated and not used enough. And actually, to pick up on a point that Partha made earlier around research and data, one of the biggest challenges, I think, is the publication bias. around, there is this obsession with publishing positive results, whereas actually there's equal value in publishing results where it didn't turn out as you'd hoped it would. But I don't think you cannot beat a good process evaluation.
Okay, Partha, you want to come back?
There's one thing that people forget when pilots. I always say this, there are 4 groups of people you will meet when you're doing anything, right? I love it. Show me some data and I'll join it. Life is so boring, I'll just join it because everybody else is doing it, and then I don't like it, okay? Pilots always attract group 1. So you will get it to succeed. The problem is not that, because as soon as you then extend it, you'll meet group 3 and 4 who are going like, I don't like it. And that's your problem with pilots. They attract people, and you already have an inbuilt bias that it will work because you've got dedicated leaders, you've got champions driving it. That's the problem with pilots. You skewed it already. The challenge will come when the variation opens up.
Okay. One last question. Anyone?
Hello, everyone. I'm Dr. Shilpa. I'm from Kenya. I have a question to Prof. Kar. When it comes to selecting the core 5, how do you select what comes under it? Like, I saw mental health, I saw oral health. Why not oncology? Why specifically? So in our country, we would probably pick up on communicable diseases, but why have you picked up on these?
Data. So those are the team which had the data which shows the impact where it's the worst. So that's your prioritization. So in the UK, there are, obviously we've got data streams as Adrian, we've got too much data, if anything, but at least it gives us the opportunity to pick. There is one also about key areas, and then I think somebody mentioned a talk, which I think is very fair. Sometimes politicians and politics has a little bit of a spin and they're bent. So for example, I think in Tony Blair, when we had Tony Blair, we had so many cardiac catheter ablation labs come around the country. It was unimaginable because he had he needed an ablation. So a lot of it is driven by also politicians, but in this case, it was very much the data which had the widest gaps in children and young people.
Okay. Any thought?
And I think there's something when you see the burden, like again with the data, when we are seeing something in just happening in the hospitals. Like I gave you example of my hospitals where I'm from, Peel. When you're seeing something, it's like right now there's a flu. I just give you example, respiratory flu is happening a lot, right? So the resources government is putting resources are more on that side. So it depends on every country has unique system, every country has unique circumstances. So it depends upon the condition and of course the data also add in that. Thank you.
Okay, but I think with that question, in fact, comes the issue of multimorbidity and the need to look at a whole patient and not just one thing at a time. Living in silos is one of our problems. So we had to get a balance there, do we not?
Which is why I think every country has got a fundamental mantra, which is fund primary care properly. They are your general practitioners. They are your multimorbidity specialists.
Yeah.
My role is to help with one particular bit. So if you want to have good healthcare system, the one thing politicians can do, if there's only one button they can press, it is get to back your primary care.
Primary care and indeed pharmacy care.
Absolutely. Yeah, part of the whole.
Good. Well, I think we've come to the end of our time for this very enjoyable and very informative seminar. And that is very much down to our 3 speakers, Katherine, Sonia and Partha. So our thanks to you and our thanks to everyone who's attended. And those thanks go to those who are online as well. Many thanks.